Yes, sir.
Okay, I had to they did something with my computer and it reset stuff, you know, upgrades, modern technology, and then I can't figure it out. I guess we're at now 4:01. So I guess we'll get started. Thank you everyone for being with us this afternoon for another meeting of our Commission to Study Mental and Behavioral Health. I want to open the meeting by recognizing that this month is National Mental Health Awareness Month. I can't emphasize enough how important it is to stop the stigma, increase the acceptance and understanding around mental and behavioral health, and to improve health outcomes. Our administration is committed and has been committed to increasing access to critical mental health resources for all Marylanders, as well as reducing the barriers to treatment, including affordability and accessibility. We have been working and expect to continue to work with our partners at the local, state, and federal level to improve the safety and quality of life and health outcomes for all Marylanders. And so with that, I'd like to present virtually a digital copy of the Governor's Proclamation. Let's see, there it is, okay. And for those who want to take a closer look, it'll be posted on the Commission's webpage, as well as some of our social media challenges. Maryland has a number of resources available for those seeking mental health services, including Maryland 211, which is available online as well as on the phone 24 hours a day, 7 days a week. Again, that's Maryland 211. And so with that, I just want to give a very quick COVID-related update and how it relates to our commission. We are just really starting to understand the long and short-term impacts of the pandemic as it relates to mental health, as well as substance use disorder. We saw from the last report from the Opioid Operation Command Center that fatalities associated with opioid overdoses and overdoses generally went up last year, and we feel that that is largely due to the COVID pandemic, the isolation, the anxiety, people who are in recovery are kind of falling back. And so there's also, it's not just affecting adults, but children alike. We've all seen loved ones and unfortunately seen people succumb to COVID. The physical distancing, the virtual learning, all of these are disruptions, and particularly for children that have endured during this pandemic. And I want to point out that last Thursday, I joined the governor and the Maryland Department of Education and the Governor's Office of Crime Prevention, Youth, and Victim Services. They used to be called something else. And the Boys and Girls Club to announce Project Bounce Back. And Project Bounce Back is a public-private partnership, $25 million partnership that supports strategic mental health services and helps expand youth development programs, and is intended to develop innovative and data-driven digital solutions to build the resilience among Maryland's young people, families, and communities. And, we all understand that positive mental health is essential to a kid's healthy overall development. And our hope is to enhance the social and emotional supports already in place to help our young people cope not only with the pandemic, but other issues that they deal with, particularly associated with adverse childhood experiences like depression or parental incarceration, health challenges, substance misuse that many are seeing or encountering before the age of 18. In the program last week, I talked about, and the principal from a local Baltimore City school came in to talk about the trauma that a lot of her kids face with what appears to be a constant epidemic of murders in Baltimore City, and how many of these children in her school that have lost parents to the carnage on the streets, and the trauma that they have to deal with, which is loosely called adverse childhood experiences. And so it's addressing that as well, and how that affects their development and ability to achieve and succeed in our society. Let me switch just briefly in terms of legislation that went through, and I know the legislators on the line are very much aware of the fact that there were a couple of initiatives that the administration put through that were recommendations that came out of this commission. One bill in particular, the Maryland Community Health and Public Safety Center of Excellence, was signed into law by the governor last month. And as you remember, in the subcommittee headed by Senator Hester, and she organized a summit on sequential intercept model back in November, which examined where people in crisis interact with law enforcement and the judicial system. This Center of Excellence was developed out of that model, or a model summit. And the goal is to create opportunities to divert individuals who are suffering away from those interactions with law enforcement and towards treatment for mental and behavioral health disorders, including substance use disorder. And the center will allow us to connect the dots between how people living with mental and behavioral health disorders are represented in and interacting with our criminal justice system and other agencies. And so that we can essentially divert them away from the justice system where appropriate, so that we can improve the response at the state and local level and steer individuals toward the resources that will actually help them. And during today's meeting, we're going to hear from Baltimore County Police Chief Melissa Hyatt and Dr. Gregory Branch, the Director of Health and Human Services from Baltimore County, on how their crisis response system provides intervention services to individuals in crisis. Separately, another piece of legislation, I'm pleased to report that the Preserve Telehealth Act of 2021 was also signed into law by Governor Hogan. And that bill, it's modeled after, it resembles a bill that the administration introduced at the start of the legislative session to expand telehealth services. And it is now something that the commission was our commission was very much supportive of, and we're pleased to see that is going into effect. Also, the Interstate Licensed Professional Counselors Compact, another recommendation of the commission, is legislation that was intended to increase access to counseling and therapy services for Marylanders. And I expect the governor will be signing that bill in the very near future. And so, as we know, the pandemic's impact on the ability of Marylanders to maintain connection with doctors and therapists, it continues to be important. And the emergency orders that were put in place help Marylanders utilize telehealth in new ways to maintain continuity of care. And so the Preserve Telehealth Act of 2021 keeps telehealth options in place until 2023, so that, and then during that time, the Maryland Healthcare Commission will be completing a study on the impact of telehealth services in the state. That's what you call a compromise. There were some that were not quite crazy about, expanding telehealth services, but they were not going to shut it down completely. So they wanted to at least have a study process. And so that's what this whole process is all about. The legislative process is about compromise, but we're glad that it's opening up. I mean, one thing, and I'm going off topic a little bit, everyone has been hearing in the news about the tragic situation in India with COVID and how it's overwhelming their hospital systems there. I saw a program where a number of Indian American doctors who were born in India but American citizens and are doctors here are basically providing telehealth services to Indians who may have milder complications associated with COVID, so as they don't have to go into the healthcare facilities, or they don't have to tie up, the medical professionals when they are having basically severe flu-like conditions, but they can be treated at home. And so I think for some of the folks that are a little concerned about telehealth services, they're here to stay. And I'm going to be pushing that we could continue, particularly as it relates to mental health services, that we take down the barriers to out-of-state providers providing healthcare services, telehealth services to people in state. Because as we've talked about, when you get outside the DC metro area, you don't have a lot of psychiatrists that can provide services to some people in more rural areas. And I think it's time that we move into this, clearly into the 21st century in terms of that. But that's my editorial comment for my first editorial comment for today. There'll probably be others. Now, at this point, as we move into the formal agenda, I think first we should do essentially a roll call. I'd like to call the members' names, and then the member can just briefly, state who they are and what they do for a living, or why they're here. You don't have to say what you do for a living. We'll start with Senator Eckert.
Very much. It's great to be here with everybody, and thank you, Lieutenant Governor, for that great wrap up. And I look forward to continued working with everybody.
Thank you. Senator Hester, I think the senator is not on, but her designee Nitin is here.
Thank you so much, Lieutenant Governor. My name is Nitin. I'm here on behalf of Senator Katie Frye Hester. She unfortunately had a family conflict arise today, but she sends her deepest regards and looks forward to working on these issues over the coming year.
Okay, family first. Delegate Kelly. All at once. Okay. Delegate Young. I see Delegate Young there.
Thanks. Good to be back again after a very intense session.
Well, welcome back.
Thank you.
Okay. Richard Abbott.
Good afternoon, Rich Abbott, Director of Juvenile Family Services, and I'm the Maryland Judiciary's representative on the commission. Glad to be here.
Very good. Trish Roddy here for Secretary Schrader.
I am here, and I think Secretary Schrader is on. I've seen him, as well as Steve Shoes. I'm here for the finance report.
Oh, okay. Yeah, there's been some, musical chairs at the health department, and when I get to formerly Director Shoe, he's moved into another role, but he's still on this commission, so.
Absolutely. So
you all will help us figure all that out. Okay. Dr. Leah Jones.
Hi, good afternoon. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration.
Good afternoon. Lieutenant Colonel Butler, Roland Butler.
Lieutenant Colonel Butler, Maryland State Police Chief of Field Operations Bureau. Good afternoon, everybody.
Good afternoon. Dr. Linda Beneski.
Good afternoon. I'm the Director of Mental Health for the Department of Public Safety and Correctional Services.
Thank you. Tiffany Rexrod, Health Department, or Human Services, excuse me.
Good afternoon. Tiffany Rexroad, Acting Assistant Deputy Secretary for Programs for the Department of Human Services.
All right. Commissioner Bahrain.
Hi, nice to be with you. Kathleen Borain, Maryland Insurance Commissioner.
Okay, and here's the question of the day. Is it Deputy Secretary, formerly Director Steve Shue, or is it Acting Director Robin Rickard? Who's here? Or both?
I believe we're both here. Are you looking for the Crisis Services Subcommittee Chair at this moment?
No,
Or-
just this is Modiak.
Okay, then that would be acting
Robin.
Executive Director Robin Rickard.
Okay, thank you. I think Kristen Mealy was unable to attend. Mary Gable.
Good afternoon, it's Mary Gable. I'm with MSDE and work in student services and educational policy and areas of mental health. Thank you.
Okay, your volume is a little low, or maybe it's my volume. Barbara Allen.
Good afternoon, everybody. I'm with James Place, and my work these last couple of days has been helping people in recovery move from a treatment program into a recovery house.
Oh, very good. Very good. Pat Medashevsky.
Hi, Lieutenant Governor. Pat Medashevsky. I'm a family advocate with lived experience and a registered nurse.
Okay. Dr. Tipperani.
Yeah, good afternoon, Lieutenant Governor, and I want to thank you for bringing up the issue of the pandemic that is ravaging in India and also pointing out the telehealth services that are being provided from expatriate Indian physicians from the United States back to India. And I'm fully aware of that, and I really appreciate you bringing it up.
Oh, yeah. No, I mean, when I saw that, it really goes to, you know, how telehealth services can, you know, just, it expands the access to primary care. So, yeah, our you know, legislators and advocates out there need to see that as well. So thank you. Carrie Cho.
Good afternoon, everyone. I'm Carrie Cho, the President and CEO of Cornerstone Montgomery, a provider in Montgomery County. Glad to be here.
Okay, Carrie, nice background. Serena Eckwood.
Good afternoon, everyone. Serena Eckwood. I'm a family advocate and also work with NAMI Prince George's County.
Okay. And Kimberly Watts.
Everyone, I'm Kimber Watts. I'm an attorney with the Public Defender's Office and our forensic mental health. See you all.
Okay. Thank you. Our next point of business is to approve the minutes from the last meeting. Has everyone had a chance to review the minutes? Do we have a motion to approve the minutes?
So moved.
Second.
Second. Okay. Those in favor of the motion, please signify by aye or hand raise. Aye. Any opposed? Okay. They are approved. Okay, now for the subcommittee reports, and we'll start with the Crisis Services Subcommittee.
Good afternoon, everyone, and thank you, Lieutenant Governor. I appreciate being here today to give you an update on the Crisis Services Subcommittee. We met just last Wednesday. During last week's meeting, we had 3 presentations. The first was from Darren McGregor, Director of Crisis and Criminal Justice Services at the Behavioral Health Administration. Darren presented on the development of the Maryland Crisis Systems Work Group. This work group is charged with developing a comprehensive and integrated public-private behavioral health crisis services system. The work group will have 3 subcommittees to advance its work: standardization and best practices, data dashboard and systems mapping, and financial stability and sustainability. We're pleased with the work that is being done as part of this work group, as developing a comprehensive crisis response system was a recommendation that was advanced from our subcommittee in the first Mental and Behavioral Health Commission report. Next, we heard from Dr. Harsh Trivedi, Jeff Richardson, and Scott Rose about Shepherd Pratt's recommendations on expanding crisis stabilization facilities. Their recommendations included enhancing outpatient mental health centers, OMHCs, expanding certified community behavioral health clinics, or CCBHCs, enhancing residential mental health crisis programs, and removing the institutions of mental disease barrier to accessing inpatient psychiatric beds. I know this has been a persistent concern of the Lieutenant Governor. Their presentation spurred a lot of discussion among subcommittee members, and we look forward to continuing to partner with leaders like Shepherd Pratt to advance Maryland's crisis system. Lastly, we heard from Edgar Wiggins, Executive Director of Baltimore Crisis Response, Inc., about their pilot project launching in June that will divert behavioral health crisis calls that come into 911 to the city's Here to Help hotline. The hotline will be staffed by licensed mental health professionals, and we will continue to hear from Edgar as the pilot rolls out to learn more about successes and challenges. I'm sure there will be many of both. The next Crisis Services Subcommittee will be July 7th from 10 a.m. to 11:30 a.m. That concludes my update. So back to you, Lieutenant Governor.
Thank you. Thank you. Okay, and I'm not sure who's going to provide the update for youth and families. That's you. Okay.
Good evening, Lieutenant Governor and Commission members. It's my honor to provide the report tonight. The Youth and Family Subcommittee has met 3 times since the beginning of the new year, with our work groups meeting more frequently. Yesterday, we had our 3rd meeting. We were very pleased to have Dan Martin with the Mental Health Association of Maryland give a presentation to the group focused on a review of the 2021 legislative session. Many priority issues were discussed, including the impact of COVID-19, access to service with an increased demand, efforts to reduce disparity, access to telework, and crisis services. With respect to the conversation and work regarding the danger standard, the work group met 3 times. Members were encouraged to review the Grading the States report, as well as review other language examples from other states. In the end, a consensus among the work group could not be reached on the language of the standard. Some were not comfortable with any of the state language they reviewed. Others did not believe the current language should be changed, either because they were not convinced it resulted in widespread barriers to care, they were concerned about limiting the discretion of clinicians, or they were concerned about inappropriate use of involuntary treatment. The group agreed that extensive training on the interpretation of the danger standard for all groups that utilize the standard is important. However, there was no agreement on whether the training should occur prior to or after passage of legislation to define the danger standard. There was also disagreement on how that training should be conducted to the varying entities and individuals that interface with the statute. Our work group had a presentation by the Behavioral Health Administration to discuss their work surrounding this issue and how we could be a resource. With many of our work group members also attending the Behavioral Health Administration's Involuntary Commitment Stakeholder Work Group, we felt our work under this subcommittee could shift its focus to a different topic and allow the Behavioral Health Administration to take the lead on this issue. Finally, our subcommittee began scheduling presentations for the next few meetings to better understand the complex system surrounding our crisis services for children and youth. We plan to reach out and work collaboratively with other subcommittees under this commission on this issue. That concludes our report.
Thank you very much. And I do think it's worthwhile to let the behavioral health continue their process with regard to the danger standard. Okay, the Finance and Funding Subcommittee.
Good evening, Lieutenant Governor. As always, I will be sharing this report out with Commissioner Bahrain. So I'll go first. The subcommittee met last May 6th, and we have 2 more meetings scheduled, both one in July and one in September. Two key updates from the Medicaid department. The System of Care Work Group, we are continuing to meet. We met on April 28th, and as you all know, we have been trying to determine 1 or 2 small projects that we can work on in the short term. There was concern early on with the pandemic and some other issues, operational issues. And so the group agreed that we should focus on 1 or 2 projects that we can concentrate on in the short term. To give you a flavor of some of the projects that we've talked about, one is a data sharing project. So CRISP, our Health Information Exchange, statewide health information exchange, has developed a consent tool that deals with, as you know, the federal substance use regulations around Part 2 and the ability to share substance use data. They have developed a consent tool which will make it easier to share data, and we're thinking through of some projects with using that tool where we can share information between the MCOs and the behavioral health providers. The second project that we've talked about is expanding collaborative care. The department and the Medicaid program.
Can I interrupt for a moment? The ability to share the data, is that only for the substance use side of it and not the mental health? Because there's a barrier in terms of mental health information too.
Well, the federal Part 2 regulations are specific to substance use. And that's been a major barrier in terms of sharing data across the system.
Oh, yeah.
So we've been working. Yeah, so they've developed a tool. It's still being developed, but they're pretty long in that process. And we think it will be a tremendous opportunity for us to use it with a project with the MCOs and the behavioral health community.
Okay, because I mean, it's also a challenge on the mental health side where you may have a person that's, you know, suffering or been diagnosed with depression, but they go to their primary care doctor and not telling their doctor that they've been diagnosed, you know, separately, and they're complaining of having problems sleeping, and they may be prescribed some type of medication that, you know, with the, you know, that the disclaimers on the medication say that it could lead to suicidal thoughts. You know, if you have these thoughts, then you should contact your doctor, and not knowing that could be a challenge. So, okay. But I'm glad they at least did that, because a couple of years ago, and I actually did testify before Congress and said that this was an issue in terms of the substance use disorder side, and the congressional members of the committee were shocked. They didn't even know that this was the case. Well, I can understand. I don't know all the laws of Maryland, so we can't, you know, expect them to know all the laws in the federal government. But it was the subcommittee that would be charged with this, so I'm glad that they made that change. So
I agree. And then one other project to kind of talk about is collaborative care. This is where you're treating sort of the low-level behavioral health disorders in a primary care setting. we have a small pilot program. It's only about 550,000. And there was discussion about working with the work group on how to expand that program, how we would design it, if we would pick certain counties, et cetera. And then, so what the next steps are is we're bringing this back to our internal steering committee. We're going to report out all of the comments that we've received, and then we will determine 1 or 2 projects to move forward on. The other update that I wanted to provide, which I'm really happy about, I presented that we were going to apply for an amendment to the Psychiatric Institution for Mental Disease prohibition. So we are submitting our 1115 waiver, and included that is an amendment to those rules. We're asking for 2 30-day non-consecutive stays, so up to 60 days a year. So we're really excited about this opportunity. As I presented in the past, you know, it all depends on the policy of CMS. They have denied us in the past, or they've asked us to phase these provisions out of waivers. So we really encourage you all to write letters of support to our application. And in a minute, I will put a link to our application in the chat box so you can all take a look at it. We are accepting public comments through June 4th. We had our first public hearing today. We'll have another public hearing as well, and all those details will be in the link. But again, really encourage you all to write letters of support. And obviously, if you have questions or concerns, to let me know as well.
Okay, has the governor signed a letter of support? Have we asked the governor to?
We haven't yet, but I would love to do that. I think that would be great.
Okay, I think we should put through a request that he sign one, and he and I can send separate letters because I can sign it under the commission, you know, as Lieutenant Governor, and the Commission for Mental and Behavioral Health. Unless one of the members objects to me doing that, I can do that. Well, it needs to be more than one person objecting. So, okay. All right. Well, thank you. But yeah, we'll look at that. I'll ask my staff to reach out to you, and we'll get that information.
That would be great. And then we also have Commissioner Brain next.
Thank you.
Thank you.
So with the private payer market, I'll just touch on really 3 things. The mental health parity reporting regulations are well underway. We had we've been working internally to work through the comments coming out of our last hearing, talking about what are the NQTLs that ought to be reported on. The MIA let folks know that our intent was to use the 13 NQTLs that are on the NAIC's reporting tool and add one additional NQTL relating to reimbursement parity. We held a public hearing on that proposal on April 26, 2021, and received a tremendous amount of feedback. The reality is that, you know, our view is that we should add this one additional NQTL for current purposes because reimbursement rates is a consistent issue and concern between the medical surgical world and the mental health substance abuse world. The other significant issue is making sure that we move from high level guidance and direction, which has been the case with most of the the MAPIA reporting tools that states have adopted and that the DOL has adopted, and get into very, very specific, detailed, uniform templates so that we can gather the exact information we want and that there is consistency across reporters so that information can be analyzed in a meaningful way. So those were really the 2 topics that we covered on April 26th. Significantly, you know, coming out of that, I always learn something from the public because we invite the public to speak, of course, at these meetings as well, not just carriers and experts. And one of the topics that I hear over and over again as insurance commissioner is the frustration that providers have when they seek to be credentialed and signed up to be a participating provider, are told that the network is full. And then a short time later, they're asked to enter into a single case agreement because they have somebody, they can't find a provider in a particular region. So I have tasked my staff kindly to set up a meeting. It'll be a public hearing in July. We are reaching out to various providers and organizations within the mental health community to invite, because we don't have many complaints, and it may just be because people don't realize that they can come to us and share their experiences. So we'll be holding a public hearing this will be publicized shortly. It will be scheduled for July. And the specific purpose is to talk about this phenomenon that frustrates so many mental health and substance use disorder practitioners in trying to get credentialed, being told networks are full, but then single case studies. So we'll be looking at that very closely. Other than that, we are continuing with our work on the MAPIA regulations, and we expect that within the next, I would say, 6 to 8 weeks, we'll begin to put some draft regulations on our website, and we'll be scheduling additional public hearings to talk about what the specifics are. The other area of focus I wanted to mention was the updates on our network adequacy work group. We've had multiple internal meetings to go over the extensive analysis and review and comments that we received after our November meeting, after we published our draft regulations. We are holding another public hearing on May 28th. The agenda has already gone up on our website with respect to that. That will really be walking through all of the comments by section of each regulation that we didn't get through in November. But more significantly, and probably more to the point for this group, on June 18th, we'll be holding another public hearing. The agenda will go up for that, but the core purpose of that is really to talk specifically about telehealth and how ought telehealth be taken into consideration when we look at the adequacy of networks, both in terms of times to get appointments and in terms of geographic regions. And, there are sort of pros and cons, and there are different approaches to take, but we are really focused on that. And that, of course, it's important in the med-surg world, but it is critically important in the mental health and substance use disorder world. So our June 18th hearing will be very focused on that. Obviously, we'll invite everybody here who's interested to attend and certainly to speak if you like. And the final item I will mention is that the MIA will be participating in a clinic on May 20th, 2021. It'll be virtual. We'll be working with and presenting with the Maryland Department of Behavioral Health, the Baltimore City Health Department, and the Carroll County Health Department, looking at addiction, looking at its relationship to mental health, and the MIA's purpose in being there will be to talk about coverage options, your rights under your private insurance policies, and our appeals and grievance procedure. So that's our part of the report. Private market payers.
Very good, thank you. Okay, public safety and justice system.
Thank you, Lieutenant Governor and members of the commission. Once again, Nathan Venkatraman on behalf of Senator Katie Fry Hester. I'll be sharing today's report with Dr. Linda Beneski, but I'll go ahead and start here. So as Lieutenant Governor said at the top of the meeting today, we are really, really happy to see that the Center of Excellence was passed this session. That bill obviously has quite a bit of moving parts to it in terms of appointing members of the center, and then recommendations that are required to be put out by state government and local government. So we'll definitely be keeping an eye on the implementation of that legislation and reaching out to the Governor's Office of Crime Prevention, Youth and Victim Services to get updates and stay up to speed with how that center is being implemented. Tangentially related or directly related, depending on how you want to look at it. So last year's Sequential Intercept Model Summit was funded through a grant application that was filled out by Senator Hester with SAMHSA at the federal level. The second part of that grant was the Train the Trainer Summit, which is charged to the center to be completed by the end of this year. That being said, we want to make sure that we're keeping things moving and planning that well in advance to make sure that we have the amount of time to give people good notice there. So I have reached out to our partners at Policy Research Associates to talk about what needs to go into planning that Train the Trainer Summit. if you or anyone you know are interested in participating in the Train the Trainer Summit this year, please drop me a line. I'll go ahead and put our office email in the chat, and we can start planning that. So preliminary phases there, but we want to make sure we're executing on that grant application. The third portion of our work for this year, there was quite a bit of interest at our last subcommittee meeting from members and participants in housing and peer support services. So we'll be lining up speakers a little bit down the road to come join the subcommittee and talk about those issues with us, and make sure that we're keeping everyone well informed and explore what the opportunities are there. And with that, I will go ahead and hand it over to our wonderful co-chair, Dr. Linda Pineski.
Thank you, Nathan. I think you kind of covered what I was going to say. We held our meeting on March 24th, and we reviewed all 13 recommendations from the summit report. And the subcommittee did identify 2 more issues that they would like to focus on for the rest of the year, and that was housing and peer support specialists across the intercepts. Darren McGregor, he did forward us a contact for us, and so we hope to set up some speakers on the next, and then also intertwine the Train the Trainer Summit. So our next meeting will be June 8th at 3 p.m. and hopefully we can keep this momentum going.
Very good. Sounds good. Okay. At this point, we have a special presentation from Chief Hyatt, as I mentioned before, Melissa Hyatt, Baltimore County Police Department, and Dr. Gregory Branch, Director of Health and Human Services for Baltimore County. Folks, the floor is yours for your presentation.
Thank you so much, Lieutenant Governor. Thank you very much for the invitation to be here today. And everyone, thank you for the time. I'll start by saying that, again, this weekend, we had another horrific incident in Baltimore County involving, behavioral health. And it's just another reminder that, collectively, it's so great to be in the presence of everyone that's on this call about the work that we need to do together and how to be more proactive and productive in some of these cases. So early in April, County Executive Olszewski, along with Dr. Branch and myself, announced a pilot initiative in Baltimore County to increase the services for us to be able to provide for individuals that are coping with behavioral health challenges. And I'm going to present the first portion, and then I'm going to turn it over to Dr. Branch, who is far more of an expert than me. But this initiative is going to provide us with an opportunity to expand the capacity of our current mobile crisis team while also establishing a call center clinician program. And the new program is going to allow us to not only screen calls, but also really to offer early diversion in our 911 center. And as we begin, I want to point out that this has been a very collaborative effort between multiple county partners under our county executive, been incredibly supportive. And this is really about us having the ability to work together to provide the right resources at the proper time to people that need them the most. So in terms of our purpose with this presentation and really with this entire project, the inspiration for this was really reflecting on the number of incidents that our police officers continue to encounter with people who are experiencing a behavioral health crisis. And as we know, unfortunately, far too frequently, these incidents result in some type of conflict. And that could be everything from a use to force situation to an individual entering into the criminal justice system or somebody that, is a consistent drain on our emergency medical system, somebody that needs other resources. And most of these folks under most circumstances are not criminals. And what we see is rather than having our patrol officers continue to be that initial point of response to many of these calls for service, some of these individuals need to be connected to proper resources and services. And as Dr. Branch is going to discuss in a few minutes, the pandemic has really amplified our need in Baltimore County, and I'm sure I can say collectively, to address the issue as the necessity for services continues to grow. In terms of background, although the screening and diverting of calls coming into our 911 center is going to be for us, our mobile crisis team was actually established in Baltimore County in 2001 It was a pilot program in one sector of the county and was ultimately expanded countywide in 2008. And then in 2018, our program was ultimately expanded to be a 24/7 response across Baltimore County. As you can imagine, back in 2001, long before I was in my role, our program was one of the early ones to be seen around the country. And the best way to describe the Baltimore County Police Department's mobile crisis team is that it's a co-responder model, often referred to as the Memphis co-responder model. And we take specially trained police officers and we pair them with behavioral health clinicians responding to these calls for service. We use this as an alternative to that traditional response of a patrol officer responding to behavioral health crises. And what we do know is that this quick responder model, which rather than having our police officers dressed in traditional police uniform, has them dressed in soft clothing like polo shirts and slacks, along with clinicians, really increases our ability to de-escalate situations, to connect with people who are in crisis, and really to successfully resolve situations. Again, our goal really is not to arrest our way out of these situations, it's to connect resources to people in crisis. We don't want to harm them, and really, in many cases, we want to minimize our interactions when we can. Our current program has been successful, and in fact, in 2020, they handled 2,719 calls for service and diverted 921 individuals who were in an acute behavioral health crisis to specialized services and resources, with an additional 1,348 cases referred to community health options. Unfortunately, we have a significant capacity limitation, and while currently we have 2 mobile crisis teams per shift operating countywide, when we looked at our total calls for behavioral health needs, we are only effectively sending mobile crisis out to 44% of those calls for service. So we don't have the capacity right now until we do this expansion to respond to that other 66% of calls. And further, and maybe even more importantly, is that we don't have the ability or any ability to divert those calls for service prior to dispatch, which effectively means that one way or another, police officers are being dispatched to every single behavioral health crisis call for service. And in plainer terms, I would say that our mere presence, sometimes the sight of our uniform, our professional mindset of, kind of needing to resolve situations, just is not always the best mix with these behavioral health crises. And again, we realize that we are still only sending our mobile crisis teams to 44% of these calls for service, which means that the other 66% of the calls for service are going to patrol officers, which simply isn't ideal. Over the years, we've grown our mobile crisis program. We did those expansions, but we still have a lot of work to do. In terms of our approach, our focus with this pilot was really to really streamline it and look at 3 things. Ultimately, we had to narrow our focus down to 2 of them. And I'm going to discuss all 3 of them, but I'm going to focus on the 2 that we were able to approach first. So our first focus was to increase the capacity of mobile crisis, to be able to get them to as many calls for service as possible. Our second focus was to enhance early diversion prior to police response at the time of that actual 911 call coming in. And then our third focus, and I'm going to talk about this one briefly, but again, unfortunately, at the moment, we don't have the capacity for this, although it is just, we continue to have reminders of why it's so important. Our third area of focus was referrals right now come in from police officers to what's referred to as IHIT, which is really a follow-up component. But really what we want to ultimately build is some type of capacity for community referrals, where rather than people calling 911 about concerns about someone in crisis or issues that they feel like they need to have resources for, having the ability to contact professionals or clinicians to connect the proper resources for people. We frequently, sadly learn after a crisis that the community knew that an individual needed resources and the police maybe attempted to assist, but either lacked resources or didn't know how to locate the proper resources. And, we do have, of course, have people that continue to function in a state of crisis in our communities and continue to come in contact with our police officers during those states of crisis. So our goal is to build resources in place for increasing contacts with these individuals, making sure they're going to appointments, maybe taking medications, things like that, before they get to that crisis moment. And the hope is that by being proactive, keeping them safe, that hopefully we can ultimately prevent that flashpoint crisis moment when our officers encounter them when they're in crisis. So in terms of increasing our capacity and investment, again, the first priority was to increase our mobile crisis team. So currently, we have 2 teams that operate during our day and evening shifts, and we're going to be increasing that to 3 teams. And the way that our county is rather large, the jurisdiction geographically, and our patrol resources are broken into a central, east, and west component. So now we will be able to place a mobile crisis team into each of those areas during day and evening shifts. Currently, during our midnight shift, that's our low call volume time, so we won't be expanding to 3 teams for that. These teams really during peak hours are going to actually, during those peak hours, expand their capacity by up to 50%, which will be very, very effective for us. And I would say probably one of the other important statistics to talk about, and this again is something that we're optimistic about, is that while we are in a time where we're struggling to maintain police staffing, we know that the average behavioral crisis call takes an officer out of service if we're lucky for an hour, but often it's far longer than that. And when we looked at the statistics, we predict that this pilot program will actually reduce our patrol officer response by up to 900 hours annually, which will allow them to spend more time in neighborhoods and responding to other calls for service, which is of course during this time is really important to keep our communities safe. And when we look at the additional investment that you can see will be reflected, I'm trying to get back to that, Dr. B. Okay, when we look at this slide in terms of investment, this is what we would be looking at from the police department, and this is what we would be looking at from the health department in terms of increased resources. Before I turn it over to Dr. Branch, I just want to touch briefly on our call center. So as I noted before, this call center piece is probably the most significant for us. And we consulted extensively with our peers in both the Houston Police Department and the Austin Police Department, as they have done a lot of work with these call center clinicians, and their diversion programs are doing quite well. So a lot of what we came up with for this models what they are already doing and doing well. So essentially, to begin with, we're going to be staffing the call center during the day and evening shifts with a clinician when call volume is the highest. And, this is something that ultimately we do aspire to expand to a 24/7 capacity, but we really had to make some tough decisions regarding, priorities and use of resources to get this launched. But these individuals in the call center, these clinicians, when appropriate, will divert nonviolent behavioral crisis calls for service through connecting people with alternate services. It doesn't change the fact that when police officers need to be dispatched, that when our patrol officers need to be there, if there, anything in the call for service about people being violent, we will certainly be there. That when our mobile crisis teams feel that they need patrol officers with them, of course they'll be there. But really, it's not going to be an automatic response for someone in crisis. And I think that that's what's really important to consider. At this time, I'd like to introduce Dr. Branch from the Baltimore County Department of Health for the rest of our presentation.
Thank you so much, Chief Hyatt, and thank you, Lieutenant Governor, for inviting us. I'd like to say hello to my boss, Secretary Schrader, and give everybody else a virtual fist bump while we're here. So just talking a little bit about our crisis response system for Baltimore County. Our objective is to provide accessible, coordinated, and comprehensive behavioral health services. We need to really fill the service gaps, and we have to offer an alternative to the emergency rooms. The emergency room is not the answer. We've got to have alternatives to the emergency room. And for that matter, we've got to have alternatives to the detention center. So the service components that we have in our crisis response system is a mobile crisis team, our hotline and our operations center, in-home intervention team, urgent care center, critical incident stress management, community education, and then obviously the crisis intervention team training. That is extraordinarily important. We must train the crisis intervention team. So I guess, but like I guess mentioned that everybody probably knows this, we've been talking about this for this whole meeting. With the pandemic, there are so many contributing factors that to the decline in the mental health in our communities. With the pandemic, we've got increased stress, social isolation and loneliness, trauma, environmental factors. Bereavement is very, very, very high. We've got so many folks who are dying at this point because of the opioids, COVID-19, the suicides, the gun violence, and then obviously the adverse childhood issues that are happening at this point now, the ACEs, all of those things put together. And what we're recognizing is that that compounding effect is happening a lot within the same families. So we know for Baltimore County in our data, over 5,500 residents access the inpatient and emergency department care for suicide and self-harm concerns. And that was in fiscal year 2020. Individuals 18 to 24 represented 12.7% of those total visits. Very important. It's getting younger and younger and younger. And we can say that the MDH data shows upward trends of intentional harm by individuals that are ages 10 to 19. The Baltimore County Child Fatality Review, and that's the program that reviews all of the child fatalities in Baltimore County. And they've recorded an increase in youth suicide deaths, which is surpassing the homicide and accidental deaths. And we've also noted that the Black youth suicide trend line is increasing above that of the white youth suicide trend line. And we are definitely noticing that trend. Those numbers are not tremendous, but that trend is very, very, very real. So overall, this is a very, very important program for us. I just threw up the numbers here from the financial investment that Baltimore County is putting into the program as we talk about this particular pilot program to increase. Obviously, there are more things that we need to do and that we will continue to work on for Baltimore County. But I think that this is a great continuation of what was started in the early 2000s in Baltimore County. And that's it.
Well, thank you. I'm going to ask the commission if they have any questions. I'm going to ask a question. I don't know if you're going to be able to answer this. And it's Chief Hyatt, you had mentioned the 3 priorities and the third that you haven't been able to implement. What does it take? And maybe it's a 2-part question. What would it take to implement getting the community referrals? And then what can you do once you get the community referrals? And maybe that's a question for what you can do is also goes to Dr. Branch.
Yes, sir. So I'm going to start answering that, and then I'm going to turn it over to Dr. Branch because he's definitely the expert on this. You know, from the law enforcement end, where we really struggle is that we don't get a lot of community. There's not an element set up effectively for community referrals. So when people have concerns about a family member or someone in their community, the only avenue for those concerns to come in are through 911. We don't have established avenues set up where, you know, experts, clinicians, individuals that certainly understand mental health, behavioral health better than police officers are able to manage some of the concerns that come in. And I know that that is something that is starting to occur elsewhere. And I'm going to turn it over to Dr. Branch to probably do a far better job articulating that than I just did.
So you did a great job, Chief. Basically, what happens is that we're trying to be proactive as opposed to reactive. We're trying to do preventative stuff. So we all may know somebody in our communities or in our families that have mental health issues. And we may recognize that if we can get them help prior to the crisis, we could not only prevent the crisis, but we can help the individual and the community. And that's the key. Having the resources to be able to set up an infrastructure so that the community can communicate with us when there's an issue with an individual or groups of people. And then having the ability to be able to interact with that person prior to them going into major crises. Prevention is the key. Waiting for the person to be in crisis, and then we've got an incident that we're trying to now be reactive to, did not save the lives and the trauma that we can do. So the whole idea of that whole piece is to really be proactive, not reactive, and be preventative.
And Dr. Branch, if I could just add, you know, I think that people are reluctant. They don't want to call 911 about a family member. It's not comfortable. And certainly there are communities that don't have a lot of comfort and trust in law enforcement. And they know when they call 911, they get concerned about what that outcome looks like. So they don't call. And, you know, it does not give us as a community, and I say community because it's a lot of different partners, the ability to look at the situation and determine which resources are needed to, you know, make sure this individual is, maybe it's something as simple as going to doctor's appointments, taking medication, just checking in with them. That way, if they're starting to get to the point that they feel like they are moving towards a behavioral crisis, there can be some intervention, like Dr. Branch said, before they get to that flashpoint moment.
Yeah, I mean, I agree, and I'm going to call you Dr. Hyatt, but Chief Hyatt, you may be a doctor also. But you mentioned before, just showing up in uniform can often escalate the situation, because if that person is in crisis, they could very well be paranoid about anyone, any person, and particularly an authority figure. Has there been any thought or reaching out to providers that may be in the private marketplace, the nonprofits? I know we have Carrie Cho from Cornerstone Montgomery. They're in Montgomery County, but I'm quite sure there are entities similar to hers in Baltimore County that could be in a public-private partnership, you know, the network of those kinds of providers, that the calls can go to them or be deferred to them. You know, not in the crisis situation. I'm talking about on that preventive side, you know, where there's a safe place, in a sense, to call to say, my cousin, my neighbor, my son, you know, he or she is having, you know, has a mental health issue, and they're starting to drift or deteriorate. You know, how do we get help for that person? And, you know, particularly if they're an adult, it's that, you know, family member can't do anything if they're an adult for the most part. But just wondering if there's been any thought, and I don't know if anyone else on the commission, you know, in terms of looking at how to implement that part 3, that proactive aspect of it. That it's not a 911 call, or there's some other, like the 211 call, you know, for mental health crisis, that it goes to another place that this referral could go to. Anyone? Any ideas?
Well, I know that I recently had a conversation with, actually, it was one of the fire chiefs in Montgomery County about doing different things with when EMTs are called out and get to a behavioral health situation. And they've been working in Montgomery County on doing what you're talking about, having places to send them instead of taking them to the emergency department. And we've talked about that one of those places could potentially be Cornerstone Montgomery's residential crisis beds, which are supposed to be an alternative to the hospital, for example, if someone's really in crisis and needs that support right away. And then if they agree to go there, then they can help with a referral for ongoing support. And I think there's been lots of conversations that I've heard around the state about, and in fact, I think some jurisdictions have these already, the 23-hour supportive sites where people can go and be assessed and referred for support instead of an ED or, hospital, hopefully, and get other services. But I agree with you that, looking at crisis services, having crisis services is key. But if you don't have the community services to refer them to or to do preventative, then there's no point in putting a lot of money into crisis services unless you back it up with, the whole picture. And I think I know there are many conversations going on around the state about this, and which I think is good, and trying to figure out what that should look like and how the resources should be allocated to make sure that we try and cover all sides of this.
But it's kind of, there are multiple parts to it. You're right, there's a capacity issue, which you're talking about, having a place to send people. And if it's a bed or even a period of time, that's a capacity. And I know we've talked about voluntary, involuntary. That's still that's the procedure, but it deals, capacity has to be there.
Yep.
But the other, like what they're talking about, trying to address, and we saw, the incident that occurred in Woodlawn is a good example. And I think there was another incident in Baltimore County that the chief had spoken to us about earlier, where the community knew this person was suffering from a mental health issues and had not had the full breakdown, which turned tragic, but getting the community complaint that is not going to 911, that then, okay, that's a process, but then you have to have a process of getting that person some kind of assessment.
Yes.
Because if they don't want to go, if they're not in crisis right then and there, a counselor can go knock on their door and say, hey, I'm here to help. But if they feel that they don't want the help, and that's something that we have to, in a workplace environment, you can require a person to go through a competence examination. If they were at work and they're showing some signs of inability to do their job, you can require an evaluation. It's a difficult process, and it depends on the procedures of your business or whatever. But typically, you can have a competency evaluation of whether they can still do their job, and that often happens when a person is either injured or they're just showing that they can't do their job. But when it's just a private life, a person who's living on their own, that becomes more of a challenge. I mean, in terms of, even with, as the doctor and the chief were saying, identifying this person, but you may not be able to really do anything other than knocking on his door and offering to help. But if he or she doesn't accept it, then where are you?
Right. Yeah, the community referral piece that they mentioned, that's the challenge. And
yeah, I mean, it's.
But one of the beauties of this, Lieutenant Governor, is it's not one knock on the door. It's multiple knocks, right? And it's multiple knocks by different people, because we're interfacing with that person at different times. And when you've got the resources to be able to go back and to be able to continue to offer and provide and plant the seed, you may be able to help that person ultimately. What happens is that what we have is so limited at this point now that once you knock on the door, the person refuses. It's like case closed.
Mhm.
Right, I
Yeah,
agree.
no, I'm not criticizing, and saying that the knock or the multiple knocks is not something that is at the minimum helpful. It's just, kind of the top of my mind is the recent incident. But as the commission members know, this recent incident has been the fear and concern that I've had, for a long time. And that's why we've talked about what the danger standard, um, assisted outpatient treatment, what can you do, for a person who's suffering severe mental health issues. And like you said, multiple knocks at the door, there's capacity, and maybe a person who's suffering severe mental illness may at some point recognize that or feel a level of comfort enough with the person coming in, the different personality, a different person, to accept some kind of treatment. But you also may have that situation where you're rejected every time, and it just aggravates the person even more, and they don't believe you are who you say you are, and whatever their fear or paranoia is, then you become the face of that paranoia.
And
So
Lieutenant,
I'm looking for solutions. I don't know.
and the other thing that I would add, and this is really from the law enforcement perspective, is we frequently get asked questions about emergency petition, and as we know, it's very specific. It's easy, right, when somebody has that behavior that we can articulate, that is that point of emergency petition. But the difficult thing is that gap in between. Just exactly what you're saying. The person that you knock, but they don't want the help, they won't take the help, but they're it's very evident that their behavior is declining, that things are declining, but it hasn't moved to that point that we can actually have that intervention. And that's probably one of the biggest things that we struggle with in our profession as it pertains to behavioral health.
I was gonna say, well, Senator Eckert, you had your hand up. Did you want to say something before I make my comment?
Oh, thank you very much. I was just going to say it really is a community affair because those people who struggle with long-term mental illness and substance use and abuse, you don't have familiar faces. And if you haven't built any kind of continuity over time, that in and of itself can be agitating. So it's who in the system do people gravitate to? And then how do you maintain that linkage? I know we had a situation, I think I shared the last time, where we had a lady totally decompensated that kept winding up at the homeless shelter. And what they did, they would have, folks come in from the emergency services or behavioral health services, take her to the hospital, she'd be let go, she'd wind up back on their doorstep. Well, finally, they were able to get more increasing days with her and began to turn that situation around. So, I mean, it is difficult and it is labor intensive. The other issue is if somebody does have a treatment plan, can they engage with an agreement that when they do present with certain behaviors, will they accept a certain individual to be able to reach out to them? And I think that's, another issue, another intervention we've tried to work on before in our communities. It's easier in the smaller communities, I think, than it is in the larger ones. But those are some things that have had some results. Thank you, Dr. Jones.
Sure. I'm certainly excited to learn more about what's happening in Baltimore County. I read about it in the news, and I thought that it was another great opportunity to make interventions at the community level and try to keep people out of the hospital. And seems like there's a robust approach that you all are taking, a multidimensional approach which I hope that I'm sure it will probably be very effective. So congratulations to you on that. I did have a question about the utilization of peers in your work. Maybe I just wasn't listening closely to hear about peer engagement, because when we're talking about folks who are difficult to engage, peers can be really, really instrumental here. Their approach and their empathy and understanding because of their lived experience can be very helpful. That's similar to the model in Baltimore City with their outpatient assisted treatment or outpatient civil commitment program. I also happy to hear that there are going to be the multiple opportunities and attempts to try to engage these people with different providers trying to connect with them, because you just don't know who when people are going to be willing or who they're going to connect with or to, that will make all the difference in whether they accept your care, your recommendations, or not. So just wanted to ask those questions and make those comments.
I can tell you that we are using peers in Baltimore County, and we use peers in the whole behavioral health component. So both for substance use and mental health issues. I think we could probably use obviously some more peers as it relates to mental health, especially out in the community. But we are definitely using those folks to really help us, and they've been very, very critical in a lot of the work that we've been doing in Baltimore County.
Good to hear.
Any other questions, comments? Well, thank you, Dr. Branch, Chief Hyatt. Appreciate you're taking the time to brief us on what you're doing. There are a lot of challenges out there, and Chief, not just that our hearts and prayers go to the families affected by this recent tragedy, but also to you and your force and all that you have to do on a daily basis to try to, keep us all safe. So, thank you for what you do. And of course, thank you, Dr. Branch, for your work as well.
Thank you very much, sir.
Thank you.
Before we move on, can I just make one more point about that one?
Yeah, please.
When we did, when I did read about the incident in Woodlawn, I forwarded that to my team who's working on the involuntary commitment standards to ask, will the new standards that we are proposing, would they have made a difference in this particular situation? Would this person have been able to be kept so that they could have been evaluated? And we believe the answer to that question is yes. So, so I can get back to you about that when we, when they comb through it a little bit more closely. But I do believe that the new standards would have enabled the hospitals to detain this person.
And that's kind of I guess the point I was going to in terms of, how do you address that person? The person who is clearly deteriorating, and I think Chief Hyatt had mentioned that challenge that they have in terms of this gap that's in the system now between where you can, get an involuntary commitment and where you just kind of say, okay, they're stable and walk away. So that's good to hear. That's good to hear. Okay, thank you. Okay, at this time, we turn to the public comments. We have a number of people that are signed up, and we'll try to get through as many of the people as we can as time permitted. So I'll ask individuals to be brief, and if you're with an organization, then only one person from your organization should speak. And those who have spoken before, they may be the last people that I call upon. So let's start with James Applestein from Another Life Saved organization. Mr. Applestein, if I'm Applestein, am I pronouncing it right? Another Life organization, going once, going twice. Okay, next is a constituent, Ms. Mina Thera Marathon. I know I butchered that.
Meena Tharmaratnam. Thank you for having me.
Terramata. Okay. Thank you.
Thank you for having me this afternoon, and a very good afternoon to you all. I'm here today to urge this commission to recommend that the definitions of the danger standard for involuntary psychiatric hospital treatment specifically include psychiatric deterioration as a form of harm to self. Sometimes psychiatric deterioration and psychosis is the only evident symptom that a person's brain is being harmed. After college, my son Arna struggled with chronic lethargy, lack of motivation to seek employment, unsuccessful attempts at jobs. He did see a mental health professional at Cornerstone, but refused to accept the diagnosis and struggled on his own. I never got to understand or was, share in any of the diagnosis. I just thought he's, lethargic. A year before his suicide, he decided to travel the world and paint. It was his therapy. The mania and psychosis came some 6 months before his suicide, when the psychosis started. He would call and speak about hearing voices through the TV. The Pope spoke to him in his book that he was writing. The painting that he was doing of the Trump's America. He was imagining that he's selling it for $10 million. And then the psychosis became worse and worse. And then he started talking about, the government, chasing him, CIA after him. He started talking about seeking asylum in Canada. And I still did not recognize mental illness because I'd never, because this happened all right at the end, and I had never personally had an interaction with mental illness. I asked him to come home immediately so we could just sort of figure out what's going on. The night before his suicide, he admitted himself to suburban emergency room for chest pains. But then when that took very long, the emergency room physicians weren't really listening to what he was telling them. He walked out, and next morning, in a very disturbed state, he went to the White House and set himself on fire. He died later that night. This was 2 years ago. I was devastated by the horror of the act, guilt at my inability to help my son, and angry that I had never been told by any of my doctors or therapists whom I used to go to they never suggested even once that, I should consider mental illness and go and study it and the whole disease by itself, like diabetes, like anything else. So after his death, I attended NAMI's family to family program to understand mental illness. I found my new purpose in life to help others suffering from mental illness. I don't know what the doctors in the emergency room, whether he saw any evidence of my son's psychosis. However, if he did, and Maryland's danger standard for involuntary hospital admission had included a psychiatric deterioration standard as harm to self, maybe Arnav would have been given treatment and be living today. It's difficult to predict one person who will commit suicide, but according to Treatment Advocacy Center, the lifetime suicide risk among bipolar disorder individuals is estimated 10 to 15%, and 5% to schizophrenia, with higher rates early in the illness. Major risk factors include lack of treatment and poor adherence to medication. Surely a psychiatric deterioration standard that facilitates early treatment of psychosis would have a good chance of saving some lives and certainly helping others to function. Arnav was the kindest, gentlest. I loved him. It was such a wasteful loss of a young life. Thank you.
Thank you. And we all are sorrowful for your loss. And I just want to say, it wasn't your fault. It was not your fault. you did what you could and you did not, know what the problems are. And that is a challenge for family members who have adult children or adult family members that are suffering, because the protections in our medical system does not allow for that information to go to you unless it is approved or you have, a legal right. But I just wanted to state it's not your fault. And thank you for advocating for changes to the danger standard. And that is something that our department, and you just heard Dr. Jones say that they are working on the danger standard to try to address these types of situations. So
Thank you for having me.
thank you. Okay, Gina Beck.
Okay.
Hello.
Hello, Ms. Beck.
Hi, thank you. My son is 29 years old. His name is CB, and he was diagnosed with schizophrenia at age 24. In 2019, he was living successfully in supervised housing and then stopped taking his medication. He remained unmedicated for 16 months, experiencing extreme psychiatric deterioration and becoming very delusional and paranoid. The danger standard was a barrier to the hospital treatment he desperately needed to recover. 4 times the group home directed his teams in hoping of getting CB petitioned for voluntary psychiatric evaluation for hospital treatment. One time when staff members asked CB to cooperate with house rules such as bathing and doing chores, he displayed extreme psychosis, agitation, ranting, making wild accusations, and had absolutely no grasp on reality. He barricaded himself in his room with a mattress. The mobile crisis team decided, as they had on 3 other occasions, that he did not meet the danger standard. Having psychosis and experiencing
I'm sorry, you break up from time to time. I don't know if it's you're in movement or it's just where you're located. It breaks up. I'm hearing most of it, but it's
Okay.
every now and then it breaks up a little bit.
Okay. I'm in a car, so that could
Okay.
be it.
Yeah, I can see the
Anyway,
seatbelt.
I'll try to get through the rest of it.
Oh yeah, please.
Having psychosis and experiencing psychiatric deterioration was not considered to be a danger to self or others. A few weeks later, he attacked the group home director, knocking him down a flight of stairs. Finally, CB was involuntarily hospitalized and given medication over his own objection. The hospital tried to release him prior to the commitment hearing, and one day after starting medication over his objection. Clearly, the hospital too did not consider active psychosis and psychiatric deterioration to meet the danger standard, nor were they willing to take into account his past history of harm to others while psychotic. I had to threaten legal action to keep him hospitalized until he stabilized. Consequently, he's now medicated compliance and he's successfully living in a supervised outpatient program, but it should not be so hard. Psychosis is real and dangerous to the ill person and others. Research shows that untreated psychosis reduces the chance of recovery, causes brain damage, and increases the risk of homicide 15 times. The latest danger standard proposal by the Behavioral Health Administration would still be a barrier to the timely treatment of psychosis. Therefore, I urge the Commission to immediately recommend to the Governor that the administration's proposed danger standard be revised to specifically incorporate, as many other states have, psychiatric deterioration as a danger to self, reasonable expectation of harm to self or others, or inability to care for self, rather than requiring completed violence threats or waiting for current inability to self-care. Consideration of personal and medical history. The danger standard should be based on established scientific knowledge, not political expediency or consensus. I thank you for listening to me today.
Thank you. Thank you very much. I appreciate that. And we're taking down what you say, and, we'll be looking at that as a commission as well. So thank you. And, and hang in there. I mean, I don't know if you've heard my comments for time, that what I've talked about is exactly the situation that you're in and Mina before, that when you have adult family members, it is very difficult to get them the kind of treatment for as long because they're considered competent, which
Yes.
does not, because competent to make their own medical decisions. And and other family members know that he is not. So that's the challenge that we face, and we have to continue to work to improve that process. So thank you for your testimony.
You're welcome. Thank you.
Avra Sullivan, Chesapeake Voyagers.
Good afternoon, Lieutenant Governor and Commission members. Thank you. Thank you first for your dedication to improving our behavioral health system and care, and for this opportunity to speak with you. My name is Avra Sullivan, and I am the program coordinator for Chesapeake Voyagers. We are one of 23 peer-run behavioral health, wellness, and recovery centers within the On Our Own of Maryland network. We are located on the Eastern Shore. We have been able to assist with successfully de-escalating crisis situations and preventing unnecessary, costly, and often harmful psychiatric hospitalizations. The strong relationship we have formed with our local crisis team has allowed us to quickly reach individuals experiencing crisis. Stigma and feelings of powerlessness create significant barriers to individuals seeking help. Fear of the potential repercussions, the loss of autonomy, lead many to remain silent when they are most in need of support. Peer support specialists have an incredible ability to formulate trust. By validating someone's feelings and honoring their choices, we foster trust. That trust is crucial in helping people and building relationships. We can help to mitigate crisis before it ever happens through our availability to our peers. There is no time limit, there is no appointment, there is no wait list, there is no cost or insurance necessary. During COVID, one of our members who had been hospitalized in the past for paranoid thoughts began to experience them again. The thoughts escalated, he called one of our peer support specialists. Because of that trust that had been built, he felt safe to reach out during this critical time. We provided him with support, thereby de-escalating the situation, assisted in next steps, and none of that resulted in any type of hospitalization. He now consistently reaches out to us first when any distressing thoughts begin to take over. My personal struggles with mental health, as difficult as they have been throughout my life, are in a way my most powerful tool to be able to connect with and encourage those who are walking down that same path. There are hundreds of peers just like me throughout Maryland. I believe that by strategically and intentionally using the peers and the wellness centers, that we can begin to save more lives. Thank you.
Thank you very much. Yeah, I think some of the conversations we had with the police chief and the director of Health and Human Services in Baltimore County, it was talking about peer recovery and being able to help de-escalate situations. And so hopefully the law enforcement personnel in Easton and in Shore generally realize that you're a resource there. So maybe we can help get some information out. I know that Senator Eckers is on the line, so we can help getting information out to the local authorities there. So thank you again. Star Gomez.
Yes, hello.
Hello.
Hi. Thank you for allowing me to speak. I am an advocate for my adult son, and he is a 31-year-old young man, and currently he is in serving a 10-month jail sentence just since last month. But for the past 10 years, his life has been one traumatic tragedy after the next, often because Maryland's danger standard for involuntary evaluation and hospital treatment does not recognize that psychosis and psychiatric deterioration constitute a danger to self. Since his first psychotic episode at age 20, he has had 8 hospitalizations, been homeless twice, and incarcerated and convicted 4 times, always for behaviors while psychotic. The recently proposed danger standard by the Mental Health Hygiene Administration does not include a psychiatric deterioration standard. It will not help my son get needed hospital treatment before committing a crime, harming someone, or becoming homeless. He would not meet a danger standard that requires inability to care for his physical needs or threats of harm because his psychosis does not manifest in those ways. However, his delusions and hallucinations are extremely disabling and affect his judgment and ability to control his behavior. Before my son was ill, he's always been a quiet, shy, and very kind young man. After he became ill, due to his confusion, paranoid delusions, and obsessive thoughts, he was jailed for stalking, harassing, and trespassing. He was treated at Springfield State Hospital until his psychosis resolved. On release, he did well in the community under supervision for 2 years and worked at a giant supermarket. After stopping medication due to negative side effects, he became psychotic and had 3 hospitalizations within 5 months. The hospitals did not consider psychosis and psychiatric deterioration to meet the danger standard involuntary hospitalization and therefore released him prematurely. 3 times while living in a residential rehabilitation program or a crisis house, medications were changed. He was not petitioned for hospital evaluation when he deteriorated with worsening psychosis. The consequences included incarceration for trespassing and harassment, discharge from the RRP to homelessness, destruction of property, and violently attacking and injuring a group home staff member, thus violating his probation. Rather than petitioning him for psychiatric evaluation on release, the jail sent him to a crisis house while still experiencing vivid delusions and panic attacks. After 3 days of hospital treatment, he was discharged to a homeless shelter, still psychotic. There, the psychosis worsened, but again, he was not petitioned for evaluation. He endangered himself by being verbally abusive and violated parole by missing a medication appointment, and just last month, sentenced to a 10-month term in jail. I am pleading with this commission to recommend including psychiatric deterioration in the danger standard as a form of harm to self and help save my son from a terrible life of repeated psychosis, incarceration, and homelessness. Please give him a chance at a better life and protect society as well. Thank you so much.
Thank you very much. So let me understand a little bit, because we've heard it now from 3 different people testifying. Psychiatric deterioration would be looking at the history of the patient, that, you know, kind of the timeline, looking at the history to say, okay, this person is deteriorating. They're not just in a whatever state we found them in right now, but looking back to see that there's a history. Is that, am I correct with that?
Yes, that's correct.
Yeah, I would say that they're talking about looking at what the person's baseline is. If you know that the baseline is that they're able to take care of themselves or taking medication, or, you know, doing they're safe to themselves, and their behaviors are predictable for and normal for them. When you see that not happening, rather than waiting for them to get to a point, waiting for the person to get to a point where they're completely out of control and unpredictable about what it is that they might do to themselves or other, that you can intervene before someone gets to that point, which is kind of what you see on the forensic side, when we see someone who is deteriorating and they're not taking their medications anymore, they're starting to hallucinate, what's coming next. So rather than waiting for that person to get to the point where they might potentially resort to behaviors that typically happen when they become psychotic, you intervene. So that's Ms. Gomez, am I capturing that right for you?
Yes.
Okay. All right. Well, thank you. Thank you for that, your testimony and comments. Okay. Next, I'm not sure if Rajani Gudavarty is on Baltimore Harm Reduction Coalition. We didn't see his name or her name. I'm not sure. Hello, is she on?
Yeah, it's me.
Oh, there. Okay, I'm sorry. I couldn't tell.
No worries.
Male, female.
Yeah, no
names
problem.
now. When I grew up, I had a friend named Travis who was a guy, and then later met a Travis who was a girl. So I don't know, but it's fine. Fine with me.
Yeah, all good, all good. No problem. Thank you so much for having me and for giving me space. And before I speak to what I was going to speak on, which is quite different, I just want to say thank you so much to the mothers and folks who've really touched my heart speaking today. So my name is Rajani Goodlove-Letti. I'm with Baltimore Harm Reduction Coalition. I am here today because we wanted to ensure that Senate Bill 420, which passed the General Assembly on April 12th, has the support of this body, if not just more understanding with this body. So Senate Bill 420 reduces legal barriers to syringe access. It aligns criminal law with widely accepted public health practices, advancing racial justice within public health, saving costs, stopping unnecessary arrests, and improving the collective impact of drug treatment outcomes. The use, possession, delivery, or sale of paraphernalia to inject, ingest, inhale, or otherwise introduce drugs into the body is a criminal offense in Maryland, unless an individual is enrolled in and obtains supplies through a syringe service program, which we call SSPs, approved by the Maryland Department of Health. So speaking on behalf of one of the largest SSPs in the state, proving that you are one of our clients is confusing and applied very differently when up to the discretion of individual police officers across the state. SB 420 is the only bill on the governor's desk dedicated to reducing leading causes of overdose. Every scientific and medical organization to study the issue has concluded that sterile syringe access reduces the spread of HIV, hepatitis, and other bloodborne diseases. Such access reduces stigma associated with drug use, encouraging people to come out of isolation, seek healing and health services, and that reduces overdose risk greatly. Unfortunately, interference by the criminal justice system often creates cavernous barriers between our clients and access to life-saving services. Just a couple weeks before MGA passed SB 420, a participant of an authorized SSP was arrested and jailed for attempting to bring items considered as paraphernalia to a loved one in another county who needed these life-saving supplies. Regardless of whether or not the charges are dropped on that person, this person has had their life turned upside down, spent multiple days risking exposure to COVID, and has not been able to attend to their loved one's health needs. This story is all too common in Maryland, and so we need to decriminalize possession of paraphernalia under any circumstances right now. Thank you so much for listening and for this time today.
Okay, thank you. I'm not sure where that bill is in the process in terms of being in the governor's office, and I will check on that and make sure people understand the position that you raised. So thank you very much. We have Michael Gray from Treatment Advocacy Center, IMD Labor. Michael Gray.
Sure. Mr. Lieutenant Governor, members of the commission, thank you so much for giving me a couple minutes to speak. And wanted to address something that Assistant Director Roddy mentioned earlier, which is something I know is very important to this commission. That's the draft application for an SMI IMD exclusion waiver to Medicaid. Such an important thing. And at the Treatment Advocacy Center, we're so happy to see that application being drafted and being open for comments. There is one unusual aspect of it and compared to other states. So far, 9 states and DC have applied for these waivers. 7 of those have been approved, 3 are pending and shall be approved pretty quickly, we think, pretty soon. And Maryland is the only one that limits in 2 ways, limits a total of 60 days under the waiver, 60 days of stays in an inpatient IMD bed, and limits to 2 stays, 30 days. So in other words, a limitation of days total and a limitation of 2 stays in a given year. I not only respect what Maryland Medicaid has said about this, that they're getting that because of feedback from CMS, but just wonder why Maryland is the only application to reflect those limitations so far. Other states have same numbers used in very different ways. Other states have an average length of stay of 30 days statewide. That's a CMS requirement. And that individual stays do not exceed 60 days. So same numbers used in very different ways. And those numbers are reflected in all 7 applications that have been approved so far. So Maryland is different and don't know why, but just wanted to bring that to the commission's attention.
So Lieutenant Governor, I'm happy to answer that. So, obviously we are happy to take your comments and we are happy to have a discussion with you and consider your comments and changes to the waiver application. Just to let you know, Maryland was one of the first states to get the SUD residential services. Again, it's an average of a 30-day stay. So if it goes beyond 45 days, CMS will go back and take money back from providers. So there is a risk there in terms of measuring that average 30-day stay. So again, we're weighing the pros and cons of each provision. Again, in some ways, we might be a bit more expansive because in total we give 60 days to individuals, to non-consecutive 30-day stays. The psych IMD is a bit different where there's an absolute limit on it. So again, we're happy to take your considerations. We actually think it might be a bit more expansive than the other states. So, I do want to at least make you think about that a little bit in terms of the data, in terms of actual days that we're covering. Again, it might look like more of a limitation, but again, 2 non-consecutive 60-day stay, 30-day stays might actually get you a bit more days. But we're happy to discuss that with you.
Thank you so much. Thank you all for your time, Lieutenant Governor and Ms. Roddy as well. Thank you.
Okay, thank you. Brian Stitten.
Lieutenant Governor, in deference to your request that you have only one person from an organization, I'm also from the Treatment Advocacy Center.
Oh, that's right. But we do have time this time. So go ahead. Just don't bleed into the next person. We have one more
Fair
person.
enough. Terrific. Thank you so much. I would also like to speak a little bit to the subject that's been addressed by so many of the families we've heard from today, which is this question of how Maryland is going to define danger to the life or safety of yourself or others in the civil commitment law. As has been discussed, BHA has responded to recommendation number 9 in the Commission's 2020 annual report, which was to establish a legal definition of danger by convening a work group to develop appropriate language for that. And I am very grateful that I was asked to participate in that work group. I've appreciated the opportunity to share the Treatment Advocacy Center's perspective in those discussions. But now that that process of having those work group meetings has concluded, I would like to express some of my disappointment in where BHA seems to be headed in developing a proposal based on what we have been told in the draft language we have been shown at that last meeting that we had. In particular, BHA has indicated that because there was not a consensus within the work group that psychiatric deterioration should be recognized as a form of danger to self, the plan is for this not to be part of the forthcoming proposal. And I just, I think really supported so much by what you heard from the families today. We just believe that it's essential that this be part of the standard. And, what we're talking about here basically is recognizing that there has to be something more than just saying a person is dangerous because they are going to harm themselves or because they are going to be unable to meet their survival needs. That absolutely must be part of the standard as well. But what we're talking about here is going a little bit beyond that to say that the risk of the harm to the brain that will result if a person remains in this untreated state is in itself, even if there is no basis to say that the person is going to be attempting suicide or starving to death anytime soon, that psychiatric deterioration, that potential for brain damage that results from untreated psychosis is itself a form of harm that we should be able to use the law to intervene and avoid when it is clear that this person can't recognize their own need for treatment and rescue themselves. And I would just kind of like to close by stressing that this is a mainstream view. You know, when you look at the states that already have laws on the books about this, you will find, although, you know, we as an organization at TAC have some work to do on this front nationally, not just in Maryland, we're at this point at 24 states that have adopted language recognizing psych deterioration as a risk of danger. And so, you know, I've shared some language with BHA from Michigan and West Virginia that I think would work particularly well in Maryland. And we understand there is a desire to have consensus among all the advocates, but I would hope that the difficulty in obtaining that, given the perennial divisions in the mental health advocacy community in Maryland, would not allow us to not take action to help these folks in such desperate need. So thank you.
Thank you. Thank you, Brian. Okay. Thank you very much. We'll continue to discuss what we can do in that avenue, in that area. Evelyn Burton. Ms. Burton.
Can you hear me now?
Yes, yes.
Okay.
And can see you too. Good to see you.
Okay, thank you. Good to see you too. And thank you for holding all these wonderful meetings. For anyone who doesn't know, I'm Evelyn Burton, Advocacy Chair for the Maryland Chapter of Schizophrenia and Related Disorders Alliance of America. And I guess I'll echo two previous speakers from a slightly different angle, but from a family perspective, we are very concerned that Maryland is not requesting the full available waiver for psychiatric hospitalizations. Other states, there is no limit on the number of hospitalizations per year at all. They're just limiting the average statewide length of stay. And definitely some people do need hospitalizations more than twice a year and do need hospitalizations of more than 30 days, which they could obtain if the average only had to be 30 days. And the other thing we're concerned about is by not doing this broader waiver, I really feel it can affect the financial stability of our IMD hospitals, because then for days that are not paid by SAMHSA, they're dependent on state funding then, which can go up and it can go down. So it doesn't give stability. The second thing I wanted to address from a family perspective too is the danger standard. And we certainly appreciate the administration's work on defining it. And I too was part of the stakeholder group. And I was very encouraged at the first stakeholder meeting when Mental Health Administration said they were committing to follow the SAMHSA guidelines for inpatient commitment standard. And that included eliminating an imminent requirement by words like significant risk in the foreseeable future, and including psychiatric deterioration language, which they suggested risk of major loss due to an inability to exercise self-control, judgment, and discretion in the conduct of his or her daily activities. But to my shock and great disappointment, by the end of the meetings, neither of those were incorporated into the draft definition that we were shown. And even after I gave them testimony from numerous families who had submitted testimony on the bill we had this year, they still did not seem interested in including psychiatric deterioration. And so I hope that they'll reconsider this and review. I'm going to submit written testimony to the commission on it as well. as well as a lot of the testimony from the families. But basically, I feel if psychiatric deterioration is not included, what am I going to say to these desperate families, some of which you've heard from today? I got a call just the other day. A family had an ill individual. The individual is experimenting with fire because of his delusions that he thinks that will save him. And it's terrifying the neighbors and their children. And he was involuntarily sent to a hospital, but he was released untreated against medical advice by a hearing judge who said the individual, quote, has a right to be psychotic. Went back to his apartment. So what about the right to treatment when you're not capable of rational thought? What about the right to the public right to safety? And these are beautiful, often brilliant young adults who wanted to contribute to society, but the state is denying them treatment to enable that. So in conclusion, I'm asking, should I tell the families that the administration and legislators fit the title of Ron Powers' book, Nobody Cares About Crazy People? They do not have the political will to fight for the treatment your loved one needs, and there is no hope. Is that what I should tell them? It's been true for 20 years in Maryland. Is it still true today?
Well, I hope not, Elaine, and, thank you. And please do submit that comment, and we'll be talking to the health department about this very issue, because I agree. And I don't think that, there are certain advocates that like the status quo, and we know the status quo is not working. And so, we have to help those parents of adult children, family members of adult family members who are, suffering. And in their mind, they're fine, and everybody else is the problem. But they're not competent to make their own decisions when they're in that state. And we have to do something about that. And so we'll continue to work on it. That's just draft comments, or draft positions. So draft means that it's not final. And so we'll go through the process, and when they're proposed, there'll be other comments that'll come in, and we'll have to work through that process too. So thank you.
Thank you.
We have a few minutes left. I don't know if there was anyone else that's on the line who didn't sign up. I could take one more comment from the viewing and listening audience. Okay, well, hearing none, we will be ending now, and our next meeting is July 13th will be our next meeting. And so I do appreciate everyone's support here, particularly the testimony that came in from the public and organizations. It was very informative. Of course, I appreciate the commitment of the commission members and the questions asked, and definitely Chief Hyatt and Dr. Branch for their presentation and the work that they're doing in Baltimore County. I understand Arundel County is doing something very similar or somewhat similar. I'm quite sure that there are others, but we do have to address this danger standard. The incident that occurred, terrible incident that occurred in Baltimore County, just really shows that there needs to be a process for getting people help before it gets to that tragic state, or as we heard from the first person who testified about her son. So we have to work on that. So again, I want to thank everyone for your involvement and your participation and passion in this area, particularly those who testified. And with that, I'll say